Today we're going to talk about surface ablation and the trans-PRK procedure. This is available on several laser platforms, but I'll be talking about the Streamlight procedure, which is specific to the Alcon machine. So what's the patient experience like when comparing transepithelial with conventional PRK? It's a much less forbidding and threatening procedure, if you like. It's faster overall, there are fewer steps. It's a true no-touch procedure. The pressure of the alcohol well and the occasional stinging of alcohol and the discomfort of the debridement process are all absent. Yes, there's a longer eczema laser firing procedure, about 30 to 40 seconds overall, and the patient does need to maintain good fixation for that, but generally that is quite easily attained. And there are definite improvements in pain scores and recovery times. Conventional PRK might use epithelial removal with an Amoyle's brush, or what I used to use, an alcohol-assisted debridement with 20% alcohol in a well, and then debridement with a blunt blade. With transepithelial PRK, there are a number of advantages. The trans-PRK only removes as much epithelial tissue as is actually required. And LASIK, alcohol and Amoyle's brushes, may well remove a larger area than is required, which both increases the time required for reepithelialization, and it may also increase the risk of recurrent corneal erosions post-operatively. The Streamlight planning is a wavefront optimized technique. It's a very small epithelial debridement zone, particularly with the spherical treatments, slightly larger when cylinder is added. There is an option to combine a topo-guided procedure by using 2 passes of the laser, but we'll confine ourselves to the pure Streamlight procedure. Epithelium removal varies from 45 to 60 micron. I tend to use 50 as my benchmark. And I tend to leave a residual bed ideally above 350 microns. The planning otherwise is similar in concept to a conventional PRK. So if we look at the planning screen itself, this is for a -4 diopter sphere. You can see that on the grayed out area there is no ablation, and this is a 6.5 millimeter optical zone. And you can see that only just over 6.5 millimeters of epithelium is ablated. So it's very sparing of the epithelial removal, just what's required for the actual ablation of the stroma. With a small sphere added, you can see that the debridement area widens out slightly, but still only what is required for the actual laser procedure. So how do I go about my procedure? There's the usual pre-op routine. We identify the patient, we add additional local anesthetic drops and antibiotic drops, we drape and place the speculum, I dry the cornea with a damp stroll just to ensure an even surface. I ensure fixation and registration and then fire the laser. I check for that epithelial breakthrough prior to the refractive component of the treatment. And then I wash with cold BSS. I apply mitomycin C 0.01% between 12 and 20 seconds. I apply antibiotic, non-steroidal and steroid drops and apply a bandage contact lens before proceeding to the second eye. Let's see how that plays out in practice. I've isolated the eye, I'm drying it carefully with a swab so that it's a nice even hydration. The laser fires after centration and pupil centration. You'll see the laser firing continuing, and now we're seeing epithelial breakthrough with a slightly more opaque center, and that's the procedure finished. I irrigate, I apply some mitomycin C, and I speeded this up, I'm not giving the full time. Remove the mitomycin C, pledge it, and irrigate again. Drops on then, and a bandage contact lens application. a very smooth and straightforward procedure, and one which the patients find very quick and very non-threatening. Let's look again at that epithelial breakthrough. One of my questions when I started this to myself was, have I removed enough epithelium? The laser chimes, and we'll hear that in the next video, as it moves to the completion of the epithelial ablation phase prior to the refractive component. And at this stage, I usually see the central 2/3, 1/3, 2/3 of the treatment area as having penetrated the epithelium. And as I mentioned, that's visible by the cornea becoming slightly matte finished rather than still glossy with epithelium still in place. And I have moved my standard epithelial depth to 50 microns from 40 to ensure that this happens early enough in the laser phase. Here's a shortened part showing that breakthrough, and then a different video showing the breakthrough with the laser chiming that you'll hear. So, straightforward process, you've got excellent control, and you can see in these shots that the epithelial ablation is only that required for the actual stromal ablation. So transepithelial PRK offers an alternative to PRK that's quicker and easier to perform with fewer instruments. It's got similar visual outcomes in my hands and in published studies to conventional PRK and LASIK. The epithelialization times are quicker than with traditional PRK methods, and recurrent corneal erosion rates are lower. And I've seen less pain with transepithelial PRK than with traditional pain methods, and again, pain scores on studies do support this. So in conclusion, the experience of my patients when I compare it to conventional PRK has been so positive that transepithelial streamlight PRK is now my mechanism of choice, and it's what I offer to all my PRK patients. I hope you enjoy using it.